Hello, I'm Taylor Thompson, a pulmonary critical care physician at Mass General Hospital, and we're going to be reviewing mechanical ventilation for patients with ARDS. These are my disclosures. So ARDS, as I'm sure this audience knows well, is an acute syndrome following a number of pulmonary insults, principally sepsis and lung infection or severe pneumonia. This leads to injury of the alveolar capillary membrane, subsequent inflammation, and increased permeability pulmonary edema. We're increasingly recognizing that there is a rapid resolution phenotype, if you will, where severely ill patients recover over days. And some patients go on to develop persistence or progression of injury, multiple organ failure, major cause of death of patients with ARDS, pulmonary interstitial and pulmonary vascular destruction. Probably one of the key factors in determining which trajectory patients will take here is a lung protective ventilation. And we're going to spend the entire discussion on optimal lung protective ventilation. So conceptually, shown here is a volume-pressure relationship with some idealized lung units. And conceptually, we would like to add positive end expiratory pressure so that lung units stay open throughout the respiratory cycle. And we'd like to choose a tidal volume such that lung units that are participating in tidal ventilation do not become overdistended and break. So we're going to talk about current thinking about selection of tidal volume to limit so-called volutrauma, and optimal techniques for titrating PEEP to abrogate so-called atelectrauma. Now shown here is the Kaplan-Meier curve for the ARDS network low tidal volume trial. The lower tidal volume mortality is shown here in red, and here is the proportion discharged from a study hospital, showing a durable effect out to 180 days. Curiously, interestingly, the detrimental effects of volutrauma in patients with ARDS are sort of maximally manifest by 21 days. So this is when volutrauma impacts patients. Now, the intervention here was 6 ml per kilogram predicted body weight. This was reduced to a minimum of 4 ml per kilogram if plateau airway pressures exceeded 30 centimeters of water. Let's just discuss a little bit about how that worked. The ARDS network investigators, you might want to think about this tidal volume titration protocol as a first order and second order scaling. Predicted body weight is used to scale tidal volume, 6 ml per kilogram, to predicted normal total lung capacity. And the drivers of TLC are height and sex. So this is a first order scale. Get the tidal volume to some measure that is proportional to a patient's TLC. The second order scaling was, as we just noted, that if plateau airway pressures were over 30, the tidal volume was reduced to 5 or as low as 4 if plateau pressures exceeded 30. So this is sort of second order scaling to the size of the baby lung. Now we're going to review some of the limitations and alternatives to titrating tidal volume this way. Well, first, is 6 ml per kilogram titrated all the way down to 4 low enough? And shown here is extravascular lung water, and this is in an acid inhalation rat model. And shown here are the various ventilatory parameters studied after acid instillation. And 12 ml per kilogram tenofovir, 6 ml per kilogram tenofovir, 3 ml per kilogram tenofovir. Shown here are plateau airway pressures. And there is a gradient of injury either by looking at lung water or looking at histology all the way down to 3 ml per kilogram with plateau airway pressures that most of us would consider quite safe. So this raises the question that the injured lung does not like to have its shape changed or is very vulnerable to mechanical injury. Do we have data for humans? What's shown here is a CT scan color-coded around CT density published by Taragni, and here is an end inspiratory CT scan. Blue represents Hounsfield units of normal lung. Red is Hounsfield's units of over-distended lung. And what Taragni did is measured CT density at end expiration and end inspiration. And I'm going to toggle back and forth and just look at the proportion of ventilated lung that turns red. Red meaning regional hyperinflation by CT densitometry. Now this could mean also reductions in regional blood volume. We don't really know, but it does suggest we're getting a fair amount of hyperinflation. And at what airway pressures on 6 ml per kilogram was this sort of hyperinflation being seen? And that's shown here on this panel. Patients that had more than 40% of the ventilated lung hyperinflated with each breath had plateau airway pressures in areas we previously thought to be safe, that is, say, less than 30. So experimental evidence and substantial human evidence suggests there may still be some volutrauma occurring at 6 per kilogram and currently used pressures. Now, recently, interest has shifted to driving pressure, to scale tidal volume, to the total respiratory system compliance. And that works something like this. Again, shown here is an idealized volume airway pressure relationship. The driving pressure is the difference between end expiratory pressure, shown here, or PEEP, and plateau and inspiratory pressure, shown here. So this would be the driving pressure. And here is an example tidal volume. Now, driving pressure scales the tidal volume to respiratory system compliance. That is to say, the determinants of driving pressure are tidal volume divided by respiratory system compliance. So if we knew a safe level of driving pressure, then tidal volume wouldn't matter. It would select a tidal volume appropriate to the compliance, or if you will, the size of the baby lung. So let's schematically show that. Let's just imagine we moved the PEEP up here and we moved this tidal volume to a more compliant part of the pressure-volume relationship, shown here. We'll go back and forth. Add PEEP, add PEEP. So the same tidal volume now has a much lower driving pressure. And if we knew again what the optimal driving pressure was for lung protection, then we could scale the tidal volume to be appropriate for that compliance. So let's look at what data we have for this. And the data come from Marcelo Amato's patient-level mediation analysis of most of the available randomized control trials of lung protection. And shown here is a multivariate risk of death in the hospital. And here is driving pressure, that is plateau pressure minus PEEP, up to as high as almost 35. And shown down here are tidal volumes. And what we can see is that there is a curvilinear relationship between an increasing driving pressure and risk of death. And this never plateaus. The line of best fit really never plateaus. And it looks like perhaps the greatest risk is with pressures over 15. Now, just for interest, I've added to this what the driving pressures were in the lower tidal volume trial. At the 6 ml per kilogram group had a driving pressure of about 16 on average, and the 12 ml tidal volume group had that should be 24, had a driving pressure of 24, again suggesting that there was no safe level of tidal volume between 12 and 6. There was some controversy when the study first came out that maybe 8 was better than 6. These data suggest that's just not true. But again, even below a driving pressure of 15, there appears to be some additional lung protection. So Titrating tidal volume to driving pressure to get the driving pressure below 12 to 15 is rational but unproven. So what have we learned so far? Inspiratory volume and pressure limitation improves outcomes across a wide range of airway pressures previously thought to be safe. Tidal hyperinflation by CT scan is observed in over a third of patients with ARDS managed with the ARDS low tidal volume protocol, and can occur at plateau airway pressures less than 30. And titrating tidal volume to limit driving pressures 12 to 15 or so is rational, but as I just noted, needs prospective validation. And there are two groups that I'm aware of that are planning such trials. That is to say, driving pressure adjusted tidal volumes. Now, there are some limitations of relying solely on plateau airway pressure that we should discuss, and so we will. If pleural pressures are elevated, plateau airway pressure at the mouth or the endotracheal tube will overestimate lung stress. Clinicians may select inappropriately low levels of PEEP due to fear of high pressures. Now, the corollary is also true. If pleural pressures are negative, you have a patient with a very strong respiratory drive developing substantially negative pleural pressures, plateau pressure will underestimate lung stress. And we can be lulled into a sense of safety when transpulmonary pressures, driving pressures, are high. So let's look at how often esophageal and gastric pressures are elevated in patients with ARDS. These are some data from Steve Loring, who compared gastric pressures and esophageal pressures in a group of patients at the Beth Israel Deaconess Hospital here in Boston. And notice these esophageal pressures were elevated in everyone. The lowest pressure in the esophagus was about 8. And this is certainly true in obese patients, patients with ascites, or patients after abdominal surgery, where, again, esophageal pressures can be elevated. Danny Talmore, working with Steve Loring at the Beth Israel Deaconess, used esophageal manometry to titrate the level of PEEP so that the PEEP level was higher than the esophageal pressure level, reasoning that if it was higher, there were, air spaces would remain open throughout the tidal cycle. These, when you do that and titrate PEEP based on a positive transpulmonary pressure estimated by esophageal pressure, these are the plateau pressures, and you can see a lot of patients in this clinical trial had plateau airway pressures well over 30. But if you looked at their transpulmonary pressure, meaning pressure at the airway minus pressure in the esophagus, the driving pressures were 8. And if Amato is correct, that would be relatively low driving pressures. So how do we reconcile this with the ARDSNet data? Well, we can't right now. A phase 2 follow-up trial is being conducted, the EP-VENT trial. And what shall we do in the interim? Well, I would offer this word of caution. If we go back to the study by Taragni et al., and we see all of this tidal hyperinflation occurring at airway pressures between 28 to 30 on 6 ml per kilogram, and then we ask ourselves if Steve Loring is correct and the pressure in the esophagus is positive, then tidal hyperinflation is occurring at pressures across the lung well under 28. So even though it appears that transpulmonary pressures in the Talmore study might be safe, we're not so sure. Now, if we look at FDG uptake in patients with ARDS and we take this region that Taragni is seeing and see if it's metabolically active during lung protective ventilation for patients with ARDS, we find that yes, it is. So tidal hyperinflation may be an important, probably almost certainly is an important injurious mechanism, and risking tidal hyperinflation by using very high airway pressures to overcome opening and closing at the lung bases, that's a trade-off that we just don't yet know which one to choose. So what to do? Well, this is my advice. Higher plateau pressures are probably safer in the obese or those with high abdominal pressures. They're probably safer because transpulmonary pressure is lower. However, lower tidal volume ventilation using 6 with further reduction to a minimum of 4 to keep plateau airway pressures less than 28 to 30 is still recommended. My advice is to play it safe. Tidal hyperinflation is a problem. And finally, we certainly need biomarkers for guiding tidal volume titration. And as I mentioned in a prior talk for this series, that's an extensive area of investigation presently. So let's move on to PEEP. Returning to the schematic, we're looking for a method to titrate PEEP to avoid the cyclic opening and closing. Now this is a little bit of an simplified schematic because we now know that throughout this inspiratory cycle here, that there's opening and closing throughout. So it's not a matter of avoiding opening and closing, it's a matter of limiting it. What do we know? We have 3 randomized control trials, or 4 now, randomized control trials of high versus lower PEEP approaches. 3 of those were summarized in this individual patient level meta-analysis, suggesting there is a survival benefit for higher PEEP in the subset of patients with a low PF, and then suggesting PEEP may be harmful in those with less severe ARDS. The missing study in this patient-level meta-analysis is Danny Talmore's esophageal pressure guided titration, which, as I mentioned before, is currently in a larger phase 2 trial. So we'll have to stay tuned on that. So this does suggest there may be some survival benefit for higher PEEP. There's no consensus on how to titrate PEEP currently. One can use a PEEP FiO2 scale. I'm going to return to some of the limitations of that approach. This is what we used in the ARDS network high PEEP trial, and the Canadians used in the lung open ventilation trial. One can adjust PEEP by tidal compliance. This is similar to the way Laurent Bouchard tested a higher PEEP strategy. We'll come back to that. I'm not going to talk much more about stress index. This is examining the shape of the pressure time curve on a constant flow, looking for overdistension during a tidal volume. We have already mentioned esophageal pressure. And then impedance measurements, which can be placed, sensors can be placed on a patient's chest, can be used to image recruitment with different PEEP strategies. That's not yet in widespread clinical use, and a CT scan, while certainly a valuable research tool, is not compatible with PEEP titration in daily care. Here's an example of the PEEP FiO2 scales from our higher PEEP trial published some years ago. And let me return to this. What this approach simply does is increases, goes up on this scale until the patient has an acceptable oxygenation, and let's say you settled at an FiO2 of 0.8 on 22 centimeters of PEEP. And then once the saturation on that combination went over 95, you work your way back down. And so oxygenation on these prescribed combinations is what drives PEEP. And Marcelo Amato and Roy Brower and I asked ourselves a number of years ago, how many, if you stay on this PEEP FiO2 scale, are there some patients we are over-distending if we simply use oxygenation to titrate PEEP? And in order to answer that question, we did this analysis. Shown here is the adjusted cumulative survival. This is the lower PEEP arm. And we looked at tertiles of patients randomized to higher PEEP by the PEEP FiO2 table. And we found that this tertile, when PEEP went up, driving pressure fell, went down 5 centimeters. So this is evidence of recruitment. That is to say, an increase in total respiratory system compliance. And in patients where that happened, their survival was quite high. However, if we increase the PEEP and the driving pressure went up, that is to say, we over-distended patients, compliance fell, and now we have a cumulative survival of only 75%. Now, this is indirect evidence of a beneficial effect of titrating PEEP by lung mechanics, but it is suggestive. Stronger evidence comes from Amato's mediation analysis. And I'd like to take you through this important slide now. So again, this is a patient-level mediation analysis. And shown here is the multivariate risk of death here. And what Amato did is looked at quintiles of patients whose PEEP, when it was increased, had no change in driving pressure. So if you increase PEEP and there's no evidence of recruitment, there's no survival benefit. Now in this, you resample and you take patients who have a reduction in driving pressure when PEEP is increased, shown here. Now this is evidence of recruitment with PEEP. And when you parse these quintiles, now you see the survival benefit of PEEP. So this suggests that adjusting PEEP to optimize driving pressure will identify the subgroup of patients who are PEEP responsive and have a survival benefit. Now this again is post-hoc analysis, needs prospective validation. So what have we learned about PEEP? Titration of PEEP by the response to arterial oxygenation alone risks overdistension and tidal hyperinflation in a significant fraction. Titration of PEEP by lung mechanics is a more sensible approach. Further study is needed to determine optimal titration methods. Is esophageal manometry the best way to go, or is driving pressure? We in our medical ICU at Mass General Hospital use best PEEP by tidal compliance and lower driving pressure by optimizing the driving pressure. And that's been our practice now for a number of years, but as I said before, it does need prospective validation. It is certainly rational. What about high-frequency oscillation, prone, and APRV? And then we'll wrap it up. High-frequency ventilation was examined in this large randomized controlled trial by Neil Ferguson and the Canadian Clinical Trials Group. Unfortunately, high-frequency ventilation for those with a PF less than 200 on PEEP showed no benefit, in fact showed a significant harmful effect. In a patient-level meta-analysis that just came out in the AJR-CCM, high-frequency ventilation for those with a PF ratio over 100 appears to be harmful, and there might be a beneficial effect for the most severely hypoxic patients in this patient-level meta-analysis. But again, there's no role for the routine use of high-frequency ventilation for patients with ARDS. What about prone ventilation? Showing here is this cumulative probability of survival in the prone group versus a supine group by the Grand Prosiva investigators. A highly significant benefit. Number needed to treat 5 to 7 to save a life. And patients in this study were enrolled with a PF less than 150. The average in Table 1 is around 100. So these are severe ARDS patients. The dose, if you will, of prone was 17 hours a day for 4 days. And the comparator was low tidal volume and lower PEEP. Now this clinical trial stands on the shoulders of many prior clinical trials. This is to say, this is not an isolated finding, nor is it unexpected. Shown here is a patient-level meta-analysis from Luciano Gattinoni. And shown here is the mortality rate in patients in 4 clinical trials in the subset of patients with a PF less than 100. And there is a consistent signal for benefit in this subgroup. 2009, 9% benefit, 2006, large benefit, 2004 benefit, 2001 benefit. And this is what the ProSiva investigators were trying to validate prospectively, and they did. Accordingly, one more observation here. In a meta-analysis by Jeremy Beitler, compared the mortality benefit of prone in the higher tidal volume era versus the lower tidal volume era, and found that prone really only works when used with lower tidal volume. So the conclusion there is prone ventilation requires low tidal volume to be effective. So this is pretty strong evidence for benefit, and there's a large effect size. The recently published surviving sepsis recommendations, just out 2 months ago in 2017, recommended using prone over supine position in adult patients with sepsis-induced ARDS with a PF ratio less than 150. The evidence base is a 1B, strong recommendation with moderate quality of evidence. So this is an important adjunct and is certainly less invasive than ECMO. It's important to remember there are some contraindications to prone ventilation, and they are listed here. I will let you read those. What about airway pressure release ventilation? This is a form of mechanical ventilation where airway pressure is set and then released periodically. In this particular graphic, they allow for spontaneous breathing on top of the P high. In observational trial or in small trials, there's improved hemodynamics, reduced intrapulmonary shunt. Patients seem to require less sedatives when airway pressure release ventilation is used versus pressure control ventilation. The concern that many have with APRV is that the release volumes, this volume right here, can be quite high, and this might actually be a form of high tidal volume ventilation in sheep's clothing. Randomized control trials are clearly needed. What about ECMO? We have one randomized controlled clinical trial now, the CAESAR trial, a multi-center pragmatic randomized trial from the UK. Shown here are the Kaplan-Meier survival estimates for patients randomized to an ECMO referral center versus kept at the referring center. Of those randomized into the ECMO center, 22 of 90 did not receive ECMO. They actually received protocolized care in an ECMO and ARDS referral center. And so the degree to which this is ECMO versus expert care is not answered by this trial. A common question arises almost every day on ICU rounds is when should we allow spontaneous respiratory efforts in patients with ARDS, particularly severe ARDS? And this is the answer I give. Certainly we know in patients with COPD that managing the critically ill patient more awake is feasible and appears to be safe. Shown here is a patient in Utah on an FiO2 of 0.6, PEEP of 18, orotracheally intubated, taking a walk. And you know where she's going? She's going in this ICU to have a shower. So this is an ICU that is quite aggressive at getting critically ill patients out of bed and managing them awake. When should we be doing this in patients with ARDS? The Papazian trial suggests we should be using neuromuscular blockade for the first 48 hours. So when do we go from this incredible focus on lung protection to allowing the patient to choose their own tidal volumes? Well, some of the data that guide that discussion come from the Awake Breathing Controlled Clinical Trial published some years ago now in Lancet, where 50% of patients in this cohort had sepsis or ARDS. And the rule there was you received a spontaneous awakening trial if the FiO2 was less than 0.5 and the PEEP was less than or equal to 0.8. And a spontaneous breathing trial followed a successful awakening. And there was no tidal volume criteria for failure in either the SAT or SBT. That is to say, they took the gloves off, stopped lower tidal volume when you reached this threshold. And when they did that, and again, half the patients had ARDS, there was a survival benefit for allowing patients to wake up, breathe, and have an opportunity for extubation. So what to do? Well, I would suggest that in the more severe end of this spectrum, low tidal volume with neuromuscular blockade for the most severe cases, prone ventilation or higher PEEP, and conservative fluid management should be done on those in this more severe end of the spectrum. And spontaneous breathing, limitation of sedation, and early assessment for weaning. And where's the tipping point? Well, we don't know for any individual patient, but on average, if you're up here, you need these. If you're down here, you need to get off the vent. And the tipping point appears to be somewhere between an FiO2 of 0.4 and 0.5 on PEEP of 8 or less. It's pretty crude. There's some evidence to support this approach. If we had a biomarker for the lung, we could be a little bit more refined. So let's summarize. Low tidal volume ventilation is safe and effective treatment for ARDS. Safe level of transpulmonary pressure, if any, in patients with lung injury is unknown. Volutrauma, biotrauma may be occurring at airway pressures previously assumed to be safe. Titration of PEEP by the response to arterial oxygen tensions alone risks overdistension and tidal hyperinflation in a significant fraction of patients. So just looking at oxygenation response to PEEP may be too limited. Titration of PEEP by lung mechanics is a more sensible approach. As I said before, we titrate PEEP to driving pressure. Further study is needed to know if that approach versus esophageal pressure-guided PEEP titration is optimal. Prone ventilation is recommended for patients with severe ARDS refractory to PEEP. If you're not doing this currently and you see patients with ARDS in your ICU, you should learn to do it. There are some teaching resources available on the web. Practice with a dummy and get competent, because this is a tool that you should have in your toolkit if you're caring for patients with severe ARDS. The impact of airway pressure release ventilation on mortality, if any, is unknown. And ECMO and extracorporeal CO2 removal, and very possibly HFO, although that currently needs more study, should be reserved as rescue therapies for patients with severe hypoxemia, hypercarbia, refractory to all the steps that we just reviewed. So I hope you found that helpful. Let's go through a couple of self-assessment questions. The following statements about inspiratory plateau airway pressure, P-plat, are true except: may underestimate transpulmonary pressure in subjects with active inspiration. May overestimate transpulmonary pressure in patients with increased abdominal pressures. You kind of have to work through that, don't you? P-plat values less than 30 are unlikely to result in additional lung injury when tidal volumes of 6 ml per kilogram predicted body weight are used. Plateau pressures usually increase when PEEP is increased at constant tidal volume. And this one is false. We have good evidence that that this is not the optimal tidal volume in some patients at plateau airway pressures of 30. The following are true about ARDS network lower tidal volume protocol, except tidal volume was reduced to a minimum of 4 to keep airway pressures less than 30. Tidal volume was increased to a maximum of 8 if patients with high respiratory drive double triggered the ventilator during a single breath. Respiratory rate was increased to a maximum of 40 per minute. Women of equal height received smaller tidal volumes than men. and intrinsic auto-PEEP was less than 2 centimeters with lower tidal volume. We didn't review many of these. You simply needed to know these. But this one is false. The maximum rate we used was 35. And it was true. Even with a set rate of 35 on 6 per kilogram, auto-PEEP was very uncommon. And finally, the following statements about driving pressure are false. It's identified as the difference between plateau airway pressure and PEEP. Values below 12 to 15 are safe, declarative statement. And a reduction in driving pressure during upward PEEP titration on constant VT is equivalent to increased respiratory system compliance or recruitment. And I say this one is probably false just to highlight the fact that the driving pressure mortality relationship never plateaus. And so I'm going to call this probably false.